Thank you very much for this introduction. I'm very happy to speak today on health system strengthening in global health research, capacity building, and policy exchange, because this is really at the heart of why I have become a researcher. I was originally a medical student, many years ago, and I did internships in hospitals in different countries, including in African countries, and I realized that medical doctors can only be as good as the health systems in which they work. And this was the reason why I wanted to become a researcher, in fact. And I went on to do a master's in health policy planning and financing before I joined the Department of Healthcare Management at the Technische Universität Berlin, where I now lead the global health focus area. And you see two additional logos here on this first slide. One is the logo at the top on health systems research and management, capacity building and health systems research and management focusing on Africa, which is a project, and I will talk a bit about that later. Another logo is the logo of the European Observatory on health systems and policies at the bottom. And I'm not sure if everybody is aware of the European Observatory, but it's quite central for the research work that I have been doing over the past 13 years at the department. The European Observatory, and therefore I want to briefly introduce the European Observatory, is an organization that tries to support and promote evidence-informed policy making, and it uses comparative analysis of European health systems and trends to give decision makers insights into how their own and other systems operate, what works better or worse in different contexts and why. And ultimately, the observatory aims to help countries strengthen their health systems to improve their people's health and well-being. And it is an organization that is hosted by the World Health Organization Regional Office for Europe and bridges the gap between research and policy making. And at the TU, we have one of 3 research hubs in Europe to provide the research that underpins the work of the European Observatory. Now, maybe those of you who aren't working on health systems may wonder what a health system in fact is. And I would like to start my talk now with a framework that is more or less 22 years old now. It comes from the World Health Report 2000, but I really like it, and it is still very influential because it has shaped the discussions about health systems at the global level. And this report, I even put it here on the slide, is also important because it has really led to it has put health systems on the international agenda and has raised awareness about the importance of health systems for assuring health improvements of populations worldwide. And the framework, the reason why I like the framework is because it conceptualizes health systems in terms of functions that a system has to perform. And every country can then have different institutions, different organizations that transform these functions into the specific national setup of the health system. But the functions, nevertheless, are the same everywhere and need to be fulfilled by any healthcare system. And therefore, it is useful to think about health systems in terms of these functions, because that helps to have a conceptual view of what a health system is and has to do in order to work. And the first function is stewardship or oversight or governance. There are many different terms for this function. That is maybe the most important function because it determines how a health system is structured and functions. And it also determines how resources are raised, how resources are collected, pooled, and used to purchase healthcare resources or services in the country. Stewardship and financing together have to assure that enough resources are created through investments and training to be able for the country to deliver the health services that are needed by the population. And of course, these health services also have to be financed through the resources that are collected, pooled, and used to purchase the services. And only if these functions are performed by a system, the system will achieve its objectives. And the ultimate determining objective of a health system, which defines a health system and the actions, the parts that are part of a health system, is that they primarily aim to improve the health of the population. But there are other objectives of systems, which include to fairly raise financial contributions and to avoid that people have to pay for the costs of ill health, and to assure the responsiveness to people's non-medical expectations, which means that health systems do not only have to improve the health of the population, but also do so in a way that the people feel respected and valued, and that they do not have to wait long times in uncomfortable environments, and that their data is protected. So there are many non-medical aspects of healthcare that are important and that need to be taken into consideration by health systems as well. Now, I already said that the World Health Report 2000 has put health systems on the political agenda. In fact, health systems have been on the political agenda for many years now, since the year 2000, at least in theory, and many people always say that health system strengthening is important, but the German government, in fact, has also played quite an important role at always putting health systems on the political agenda instead of focusing on individual diseases such as HIV/AIDS, tuberculosis, malaria, or other diseases which are often the focus of other donors, but to really, even at the level of the G7 or the G20, to discuss the importance of health systems. And this is why I put this picture of the G20 summit in Hamburg here, because in that leaders' declaration also there's an explicit mentioning from the level of the heads of states that improving and strengthening health systems is important to avoid future pandemics. And that was in 2017, so a few years before the COVID pandemic, but a few years after the Ebola epidemic, which kind of also framed the discussion already at that time. And another reason why health system strengthening is high up on the agenda is, of course, that health system strengthening are the actions that are needed to achieve universal health coverage. And universal health coverage, or in the other way around, maybe universal health coverage is a smart framing to make health system strengthening measurable, because I would say that health system strengthening has been important and has been realized as important for many years, but because it is more difficult to measure progress with health system strengthening, it hasn't received as much attention as reducing child mortality or reducing maternal mortality or reducing HIV/AIDS transmission, because this is more easily measured than the many different actions and policies that need to be undertaken in order to strengthen health systems. And by making universal health coverage a target in the Sustainable Development Goals, there is now a target that specifically focuses on strengthening health systems at this broader level of making sure that everybody receives the health services that they need without financial hardship. And this is the basis for achieving also the other Sustainable Development Goals, health-related Sustainable Development Goals, but also many other Sustainable Development Goals. But I don't want to go into these in detail. And I don't have time for that, because in fact, I want to show you some of the research that I have done related to health system strengthening, and also the capacity building work and policy engagement. And so I said that health system strengthening is the basis for universal health coverage. And what is health system strengthening? It means that health systems have to be improved with regard to their stewardship function, their delivery of services, and how resources are financed. And so I want to show you a few examples of research that aims to identify and explore solutions to strengthen stewardship, strengthen financing, and to improve service delivery in different countries. And on the other hand, I want to show you research that has aimed to uncover and quantify problems. On the one hand, problems of health systems in terms of unequal access, but on the other hand, problems of the determinants of health, of inequalities and child mortality, and maybe drivers of these determinants of inequalities. And so I want to start, in fact, with these problems and important problems of health systems. And one of the most important problems, I would say, of health systems are the large persisting inequalities that exist in countries' health systems and in countries and in the health outcomes of populations in different countries. And this is a study that I did, in fact, when I was a research fellow at the National Institute of Public Health in Abidjan in the Ivory Coast, and in collaboration with researchers in 10 major African cities. And we used the demographic and health surveys that had been conducted in these largest African cities and disaggregated the data in order to identify inequalities in child mortality in these cities. And what we found was that child mortality varies a lot across cities, but within cities, the variation is as large as the variation across cities. And that's while some cities have been able to reduce inequalities in child mortality, and in fact most have, others did make little progress. And this means that there is the need to look at the countries or the cities that have made progress in reducing child inequalities and child mortality. Another study or another big problem in health systems that I see is that gender-based discrimination hasn't really received enough attention, and that could in fact be a driver of both maternal mortality but also child mortality, because it is related to insufficient attention to reproductive health services. And this is at the basis or at the origin, in fact, also of my current GLOHRA research project, which aims to develop a tool to better measure gender-based discrimination in health systems worldwide, but with a focus on sub-Saharan Africa. And this background study, in fact, looked at the relationship between gender-based discrimination and maternal mortality based on survey data from the Afrobarometer survey. And we did find an association between gender-based discrimination and maternal mortality, but we believe that, in fact, the relationship, the association is much stronger because many women do not really understand the question whether they have experienced gender-based discrimination or not because of cultural backgrounds, norms, and values. And another study, which I want to show you in a bit more detail, and another problem of health systems is that many people have difficulties in accessing healthcare. And one of the reasons for these difficulties is that corruption is a major problem in many sub-Saharan African countries. And we try to better understand, in fact, the size of the problem, that the relevance of corruption for perceived difficulties in healthcare access in sub-Saharan Africa. And what we found was that when you look at the average level of corruption or bribery reported by people who have experienced that they had to pay extra for health services in their countries, and the proportion of people reporting difficulty of access, there seems to be an association between those countries where people more frequently report difficulty in access and those countries where people more frequently report that they have to pay bribes for accessing services. And at the individual level, when using a multi-level regression analysis, we also found that, in fact, patients who paid bribes had between 4 to 9 times the odds of reporting difficulties in access after controlling for covariates, such as the Live Poverty Index, whether or not they live in an urban area, whether a health clinic is in walking distance, and also national level covariates such as average health expenditures and the number the national level perceived corruption. So then if we know that there are many problems in health systems, it also makes sense to look at the solutions. And just as my research always looks at with an international comparative lens, kind of at what are the problems, I also usually use I very often use international comparative research to identify solutions. And one example of such a study that I have conducted with colleagues of the European Observatory of its Health Systems and Policy Monitor Network, working with colleagues in 11 Central and Eastern European countries, is to look at reforms of the hospital sectors in these countries. And to see what were in fact reforms that have been conducted over a period of 12 years in these countries, and to identify common trends, patterns, common policy approaches, and challenges to implementing reforms, under the assumption that by identifying these common reforms that have been undertaken, it would encourage discussions among policymakers about what could be more optimal approaches to address similar problems, and to learn from other countries and to investigate the approaches in more detail that have been taken in other countries. And in fact, a paper that looks in more detail at approaches that are done in different countries for avoiding hospital readmissions is this example of a paper, and similar papers could be conducted for many other aspects of hospital sector reforms to identify, to develop a framework really, which has to be at the basis of international comparisons often, because if there is no clear lens, no approach for defining exactly what one wants to look at when making an international comparison, it is difficult to compare these aspects across countries. And so we, in order to compare readmission policies, which are policies that aim to avoid that patients discharged from a hospital are readmitted within a relatively short time frame for the same problem, we first had to define what is a readmission, to look at how are readmissions measured differently in different countries, what data is used to measure readmissions, and what then incentives are in place to avoid that hospitals often readmit the same patients for the same problems. Or do they maybe not use financial incentives, but only use public reporting to discourage hospitals? Now, over the past years, of course, the COVID-19 pandemic has kept us researchers busy, also understanding what the governance factors have had an effect on how countries have dealt with the COVID-19 pandemic. And this is a study where we looked with colleagues from the United States and Israel and the UK at what can be learned from a cross-country comparison in terms of determining whether or not providers have had problems, financial problems as a result of the COVID pandemic. And we found that because of the structures of the US healthcare system, because of the large prevalence of private providers and the importance of activity-based payments, but also because in the US there have been fewer relief packages or different relief policies than in other countries, providers have had larger financial problems than in other countries. And the last paper under this group of governance solutions or studies that try to identify governance solutions across countries, I want to show a paper that has looked at the top 3 health reforms in 31 high-income countries in 2018 and 2019. And in fact, this is work that I have been doing for more than 5 years now, with colleagues of the European Observatory, and this is the first paper. We are currently working on a second paper to provide an overview of health reforms that are ongoing or have been implemented in specific years over the past to support policymakers better identify what policies, what reforms are ongoing in their countries. In different countries, and then to see similarities, patterns, and to learn from other countries what can be done. And also the EU Commission is very interested in this work because they aim to support the exchange between countries and to support like kind of communities of practice who work on similar reforms in different countries and to support exchange between policymakers working on similar reforms in different countries. And just one example from the study I want to show that, for example, we found that many countries were in 2018 busy in the area of governance reforms. There were 12 reforms being implemented in the cluster of governance reforms. There were 15 reforms related to insurance coverage and resource generation, 9 reforms in the field of healthcare purchasing and payment, and 8 reforms in the cluster of organization of hospital care. And there were clear trends across countries, e.g. the centralization of hospital care, or in the field of purchasing and payment, the reducing role of diagnosis-related group-based hospital payment systems across countries. And now, as we do this for more years, it becomes increasingly interesting to see whether there are certain reforms that have a higher rate of success of being implemented, while others are either abandoned, these are the red reforms, or still ongoing, which are the orange reforms here. And this was just with a follow-up of 1 year, but we are now collecting data for a longer follow-up period. And here we found that just after 1 year, public health reforms and insurance coverage and resource generation reforms seem to have a higher success rate than, for example, governance reforms, where most reforms were either abandoned or still ongoing 1 year after the initial year when they were reported. Now I come to the second group of studies on financing. And in fact, financing was the area which really brought me, or which shaped me as a researcher. And this is the paper that was the result of my dissertation, my doctoral thesis, where I worked together with a GIZ in Rwanda on the recurrent costs of HIV/AIDS related health services, and looked at the implications for financing. So whether or not it would be possible at the time to pay for the HIV/AIDS related costs through community-based health insurances. However, when I started becoming a researcher, I thought it's important to first understand how health systems in European countries function. And I started working in a project that looked at hospital payment systems in a large EU consortium research project that looked at hospital payment systems in different European countries, which focused on diagnosis-related group-based hospital payment, which is the payment method that is used, in fact, by most European countries. And we tried to identify in a similar way how other countries pay for hospitals and what can be learned from the experiences of other countries, but also to better understand what are better health system, better payment systems, and what are maybe payment systems that need more improvement. And we drew lessons also from for the United States. And subsequently, I looked at quite a few other aspects of payment systems upon request of different European governments who wanted to undertake financing reforms. So to inform their reforms on hospital payment, for example, here the Belgian government was interested to know how hospital specialists are paid in different countries and what can be learned from that for payment reform in Belgium, or how variable, specialized, and low volume care, which is often excluded from diagnosis-related group-based hospital payment, is paid in different countries, and whether and what can be learned from that for a reform of the hospital payment system. And of course, in the last year, with the COVID-19 pandemic, there was a lot of interest to know what can be done to adjust provider payment systems in order to support them to take care of COVID-19 patients. And together with researchers of the European Observatory of 20 countries, we have looked at the payment adjustments that have occurred as a result of COVID-19. And we clustered these adjustments into those adjustments that aim to compensate income loss, and those adjustments that really tried to pay for COVID-19 services and to encourage providers to provide these services. And what we found was that on the one hand, many countries didn't really have to adjust their payment systems, because if hospitals or physicians were paid budgets or salaries or capitation, there was no need to compensate income loss. And at the same time, these payments were supposed to also take care of COVID-19 patients, but there were little incentives to restructure activity in line with the needs of the pandemic. On the other hand, payment adjustments to pay for COVID-19 aim to incentivize treatment of patients, and sometimes also aim to steer service provision by, for example, making the treatment in special hospitals or special units a prerequisite for providers to receive the payment. And the focus of the payment adjustments initially really was to cover costs of providers, whatever it takes, while over time it increasingly became important to balance incentives also for service provision and efficiency. And from a scientific perspective, it was quite interesting to note that activity-based payments, which are usually thought to place a risk on the payer, because as activity increases, it is a risk for the payer that also total costs will increase. Here during the pandemic, we found that now it was in fact a risk for the provider, because if activity dropped as a result of lockdowns and treatment restrictions, hospitals lost a lot of income, which then had to be compensated. And the third area of research on solutions is related to service delivery. And I have looked at very specific examples of service delivery in different countries. Here's an example where I've worked with a colleague from Latvia on the provision of community-based mental health care, which could be an inspiration also for other lower middle income countries. But I want to highlight more my work on in the area of digital health or teleconsultation services. And this is really the first paper that has started this work together with a PhD student, or with a former PhD student at the time. In fact, it was a master's student who came to my office and was interested to look at a teleconsultation service in Ghana and to understand the perceptions of healthcare professionals of the benefits and challenges of the teleconsultation service in Ghana. And this has really led to the development of a research stream that focuses on digital health. On the one hand, mobile phone-based health interventions for non-communicable diseases, and research projects that focus on the teleconsultation service in Ghana. And on the other hand, also work that looks at the use of digital technologies for the financing of healthcare systems, bringing together this experience of working on digital health with my experience on working on financing of healthcare systems. But I want to highlight, in fact, these two studies, the realist review of mobile phone-based health interventions and a study that used interviews with policymakers, all from this PhD students that I supervised at the TU Berlin, but who is from Ghana, to understand the views of policymakers on how to achieve sustainability and scale up of mobile health non-communicable disease interventions in sub-Saharan Africa. And the realist review, in fact, led to the development of a framework that kind of conceptualizes and tries to better understand why, how, and under what circumstances mHealth interventions for NCD management work or do not work. And we really found that the context is important, and that the contextual factors, on the one hand, patient context factors, but also provider context factors, influence whether patients and providers find technologies useful or easy to use. And only if they believe that mHealth is useful and easy to use, these interventions may ultimately contribute to improve access to previously unavailable specialized healthcare services. And when we showed this framework to policymakers in Ghana, we found that they found it useful to guide them to a more systematic assessment of context factors that support implementation, sustainability, and scale up, because they tend to focus more on the enabling resources, but they realize that also the need and the predisposing characteristics are important and should be considered when designing and implementing mobile phone-based health interventions. And based on the input from the policymakers, we were able to refine our framework and to identify more and relevant factors that are important and should be considered when developing these interventions. Now, this brings me to the work on capacity building, which is directly linked, of course, to the work in Ghana and also related to my collaboration with Daniel Opoku, because he and I have worked together a lot on two capacity building projects that we have implemented in Ghana. They were both funded by the DAAD, and the title that I show here on the slide is in fact the second project. And in the first project, we focused more on capacity building of master's students. We developed a master's in health systems research and management that has been introduced at the Kwame Nkrumah University of Science and Technology in Ghana. And at the same time, at strengthening links between researchers at the TU Berlin and the KNUST, and strengthening capacity of teachers in Ghana who have now taken over the teaching responsibility on this Masters in Health Systems Research and Management in Ghana. And then building on the experiences of this first project, now in this follow-up project, we focus more on establishing the KNUST as a regional training hub for health systems research and management in Africa, because ultimately health system strengthening requires capacities at the national level in different countries of people who understand how health systems function. And establishing KNUST as a regional training hub makes it possible that researchers from different countries are trained within Africa in order to become better policy makers, better professionals. And so we are developing a series of short courses that will train policymakers, professionals, practitioners in health systems research and management at the KNUST. In addition, an important part of this project was also the development of a policy dialogue series, and I will come to that in a minute when I talk about policy engagement. And the other important capacity building project that takes up quite a bit of my work at the moment is this German West African Center for Global Health and Pandemic Prevention, which we have established at the KNUST together with colleagues from Bonn and Berlin, from the Charité and the University of Bonn and the University Hospital of Bonn, but also involving the Robert Koch Institute and several partners within Africa, such as the Consortium for Advanced Research Training in Africa, the Africa CDC, and the World Health Organization Regional Office for Africa, to really make this a regional effort at strengthening capacity also in global health and pandemic prevention research. And we are planning to train 14 PhDs and to train more than 120 practitioners and policymakers in short courses at the KNUST, and to establish a series of West African policy dialogues about pandemic prevention to bring together policymakers and researchers from different countries. And this idea, in fact, for the West African policy dialogue, this policy engagement activity originates from the European Observatories model, which was the very first slide that I showed, and where policy dialogues are organized between researchers and policymakers to exchange on important policy relevant topics, and to discuss behind closed doors what could be solutions to these existing current problems. And the topics are really driven by the needs of policymakers usually. And as part of the first capacity building project, we introduced this series of Ghana Health Policy Dialogues in 2017, and we have held annual policy dialogues now every year, except for in 2020 when we couldn't hold it because of the COVID-19 pandemic. And I said that we will use a similar model also now as part of the German West African Center to hold policy dialogues with West African policymakers on pandemic prevention. And the other, and I started this presentation, in fact, with the slide from the European Observatory on Health Systems and Policies, and I'm very happy that there's now also an African Health Observatory platform on health systems and policies, because this supports this cross-country international comparative work and the idea of learning from what other countries are doing in terms of health reforms and policies, and what can be learned from the approaches from other countries and from research on these approaches in order to improve health systems. And I'm happy and that I was able to support this initiative also with the development of a template for country health systems and services profiles, which are planned to be written now by this African Health Observatory platform on health systems and policies, based on experiences, of course, of the European Observatory, but really contextualized to the African continent and drawing on the experiences of African countries. And this brings me to the end of my presentation and to the conclusions that global health research can support health system strengthening, and research may help to, on the one hand, uncover and quantify problems, e.g. uncovering inequality of child mortality in cities, or quantifying the role of bribery in complicating access, and it may identify and explore solutions by providing an overview of health reforms in other countries or exploring reforms that have been undertaken in other countries to address similar problems. And my experience really is that many countries often struggle with similar problems, and that even though approaches can, of course, not directly be transferred from other countries, there's a lot that can be learned from the experiences of other countries in order to improve national health systems. However, global health research can lead to global improvements only if combined with capacity strengthening and policy engagement efforts, because they are needed to ensure that the research results will also be taken up by policymakers and can lead to real change. And this is the end of my presentation, and I have included a final slide, which I was asked to include by the GLOHRA Academy, on what global health research is, and I provide here my personal definition of what global health research is. That is interdisciplinary research that addresses global challenges for health systems worldwide with a focus on achieving improvements of health and equity. But I realize that this is kind of maybe a biased definition focusing on health systems, while there are other definitions, and I like the definition of Copland 2009, which is maybe more comprehensive of the breadth of the field of global health research. Thank you very much.